Hello, my name is Van de Keyser. I am a neuroradiologist working in Ghent University Hospital in Belgium, and welcome to this video on imaging of anatomy and pathology of the cranial nerves, more specifically anatomy and pathology of those nerves responsible for eye movement, so the oculomotor nerve, the trochlear nerve, and the abducens nerve. A good alternative title for this presentation could have been Imaging the Patient with Diplopia, what to double check on imaging studies in a patient with double vision, because double vision will be the main symptom or one of the symptoms in patients presenting with the pathologies that will be discussed in this presentation. What is diplopia? Well, it means double vision. There's an important distinction between two types of diplopia, namely monocular diplopia and binocular diplopia. The pathologies I will illustrate all cause binocular diplopia. What's the difference between the two? Well, let's take a look at these two patients. So both patients have diplopia. So they look at an apple and they see two apples. Now imagine that patient 1 and patient 2 are both asked to close one of their eyes. So let's say the left eye. If patient 1 closes the left eye, the patient still sees two apples. This is monocular diplopia. So the two images are seen by a single eye and a double vision persists when the other eye is closed. What does this mean? The cause for the diplopia is local. It's situated in the right eye. Could be at the level of the retina, could be the lens, whatever, but it's an intraocular problem. In patient number 2, when the patient is asked to close the left eye, what do we get? Suddenly, the diplopia resolves and the patient sees a single apple. So, this is binocular diplopia because it occurs when both eyes are open, but resolves when one of the eyes is closed. This means that the diplopia is caused by a misalignment of both eyes. We know that the extraocular muscles are responsible for the position of both eyes, and they have to work in a very coordinated fashion to make our eyes look at the same object the same way to avoid diplopia. So when a patient has binocular diplopia, there are several structures that can be involved or can be responsible for the problem. It can be a problem of the extraocular muscles, for instance in thyroid eye disease, which causes swelling of the extraocular muscles, so they probably can't function quite as good as they normally would. So it can be a muscular problem or maybe a tumor intraorbitally compressing the extraocular muscles. The problem can also be located at the interface of the nervous system and the muscles at the neuromuscular junction, for instance in myasthenia gravis, which is an autoimmune disease in which antibodies are formed against certain ion channels at the level of the neuromuscular junction. Or the problem can be situated at the level of the cranial nerves responsible for the innervation of the extraocular muscles. Now, this last one is going to be the topic of this presentation. And I divided this presentation in 3 parts. So we're going to start with a very short discussion on the function of the 3 extraocular motor nerves. Then I'm going to illustrate the anatomy of the extraocular motor nerves on imaging studies, and finally we're going to look at a lot of pathological cases, and I'm going to teach you how to approach a patient with diplopia on imaging studies as to not miss any lesions and come to a correct diagnosis. Let's start with the function of the extraocular motor nerves. So, as said, we have 3 nerves, and those are responsible for the innervation of a total of 6 extraocular muscles. So our eye movements are regulated by the workings of 6 muscles. We have 4 straight muscles or rectus muscles. We have a medial rectus muscle, a lateral rectus muscle, an inferior rectus muscle, and a superior rectus muscle. And then we have 2 oblique muscles, an inferior oblique and a superior oblique muscle. Notice the colors. So this is not a coincidence. In what is this? So kind of brown. We see the muscle innervated by the abducens nerve or the sixth cranial nerve, and that is the lateral rectus muscle. And orange, we see the muscle innervated by the trochlear nerve, namely the superior oblique muscle, and the remaining extraocular muscles, so the medial rectus, inferior rectus, superior rectus, and inferior oblique, are all innervated by the oculomotor nerve, which also innervates the palpebrae superioris muscle, which is located on top of the superior rectus muscle and is responsible for elevation of the upper eyelid. Now, what are the functions of these muscles? In some cases, it's quite straightforward. So the medial rectus muscle will adduct the eye, so move it inwardly. The lateral rectus muscle will abduct the eye, so move it outwardly. The inferior rectus muscle will depress the eye and the superior rectus muscle will elevate it. And it's a bit more difficult to understand when it comes to the oblique muscles, but the superior oblique muscle will depress the eye a bit outwardly, and the inferior oblique muscle will elevate the eye and also move it a bit outwardly. So, and then we have here the palpebrae superioris muscle, which is, as said, also innervated by the oculomotor nerve. So, okay, that's quite straightforward, I think. So we have an abducens nerve responsible for abduction of the eye. We have a superior oblique muscle, which moves the eye or elevates the eye a bit out, depresses the eye outwardly, and then we have the oculomotor nerve responsible for all other eye movements and also responsible for, I already said it, so we have the eye movement function of the oculomotor nerve, but also elevation of the upper eyelid by way of innervation of the palpebrae superioris muscle. Now there's one extra function I have to touch upon. So the oculomotor nerve, so it has a motor function, but also has a parasympathetic function. And what is this additional function of the oculomotor nerve? The oculomotor nerve also innervates the pupillary sphincter muscle, causing miosis or contraction of the eye pupil. And it also causes contraction of the ciliary muscle or innervates the ciliary muscle, causing lens accommodation. Okay, a good way to understand the function of these various muscles and what happens when one of the nerves innervating these muscles no longer function properly is by looking at what happens in a pathological situation. So what happens when a patient has an abducens palsy of the right eye, while the eye can no longer abduct, and as a consequence the eye will shift inwardly. Let's look at some pictures of a real patient. So this is neutral gaze, and when we look at the right eye, we see that it has shifted discretely inwardly compared to the left eye. When the patient is asked to look to the right eye cannot abduct, so it does not abduct as it should. And when the patient is asked to the left side, well, no problem is there, because the medial rectus muscle is innervated by the oculomotor nerve and not by the abducens nerve. What happens in a patient with a trochlear palsy, once again of the right eye? So the superior oblique muscle no longer does what it is supposed to do, which is depress the eye outwardly, and as a consequence the eye will shift in neutral gaze superiorly and also a bit inwardly. Let's look at a real patient. This is a patient with a right trochlear palsy, and one thing we immediately notice, that is that there is a slight head tilt, and that's what patients with a trochlear palsy often do. There's a slight head tilt to the contralateral side to compensate for the trochlear palsy. If you look at the position of the eye, we see that it has shifted upwardly and a bit inwardly compared to the normal left eye. And finally, what happens in a right-sided oculomotor palsy? Well, the only extraocular nerves that are still functioning are the abducens nerve or the only muscles that are still functioning are the lateral rectus muscle and the superior oblique. So those are responsible for abduction and also outward depression of the eye, and as a consequence the eye will shift down and out, as they say. Now, when the oculomotor nerve is involved, in some cases the parasympathetic fibers can also be involved, because those are responsible for meiosis. Meiosis is no longer possible and the eye will look blown out, or the pupil at least will look blown out and be in mydriasis. But that's not always the case, so it depends on whether or not the parasympathetic fibers are involved. And here's an example of a patient with a right-sided oculomotor palsy. We see that the eye is down and out, but also notice that the eyelid, the upper eyelid, is drooping, and this is caused by palsy of the palpebrae superioris muscle, which is also innervated by the oculomotor nerve. Okay, let's finally look at some radiological images, because this is still a neuroradiology channel, not an ophthalmology channel. And here we see various denervation patterns, and I'm using these images to illustrate the muscles being innervated by the different cranial nerves responsible for eye muscle innervation. The upper patient has a chronic trochlear palsy on the right side. And how can we tell? Well, look at the superior oblique. On the left side it's normal, but on the right side it's very thin due to atrophy. So this was a patient with a chronic right trochlear palsy. And the same patient, we also see the axial images of the same patient on the image below. This is the superior oblique muscle in an axial T2 on an axial T2 weighted image, and notice how thin it is on the left side. It's not always easy to recognize the superior oblique on axial images, so I was a bit lucky here. Generally it's easier to see it on coronal images. This patient over here, so this was also right chronic trochlear palsy, and this patient over here, look at the left eye. What do we see? Well, we see the superior oblique and we see the lateral rectus muscle, but all other extraocular muscles look absent or very, very small compared to the other side. So what does this mean? This patient has a chronic left oculomotor palsy, and in this case it was a congenital left oculomotor palsy. Here the patient on the can you recognize what is wrong with the patient here at the bottom? Let's first look at the right eye. Let's look at the lateral rectus muscle. It's normal on the left side, but on the right side there's clear atrophy. So this was a chronic left abducens palsy. So looking at these denervation patterns can be useful in patients with chronic diplopia if it's a bit unclear what nerve is involved exactly. So do it. Always check the extraocular muscles. In some cases it can be helpful by recognizing various denervation patterns as was clearly seen in these patients. Okay, let's now move on to part 2. Anatomy of the extraocular cranial nerves on imaging studies. And when it comes to talking about anatomy, we're going to... Is this bothering you? I'm going to leave it there. What was I going to say? Oh yeah, anatomy. So to make it easy, we're going to split it up in various segments. We're going to split up the extraocular cranial nerves in various segments. We have the brainstem segment, so the part of these cranial nerves located in the brainstem. Then we have the cisternal segments. Those are the parts of the cranial nerves located in the basal cisterns. Then we have a small piece running through the cavernous sinus, and finally we have the extracranial segments located inside the orbit and who enter the orbit by way of the superior orbital fissure, so SOF over here. So those are the 4 segments, and then the abducens nerve has something extra, a so-called intradural segment. So the abducens nerve, as you will see, runs through a dural-lined channel at the back of the clivus, and that's an important segment for the abducens nerve. The oculomotor and trochlear nerve don't have that, and it will be discussed separately. Okay, let's start with the brainstem, and let's first look at the oculomotor nerve. So the nucleus for the oculomotor nerve is located in the upper midbrain, and if you look at an axial image, it is located paramedially in front of the cerebral aqueduct. The parasympathetic nucleus of Edinger-Westphal is located immediately behind the motor nucleus of the oculomotor nerve, and the fibers, the cranial nerve fibers, cross the midbrain. They run through the red nucleus, which we can't see, and exit the midbrain anteriorly in the interpeduncular cistern. We can recognize various vascular structures over here. This is the basilar artery, and we see here the posterior cerebral artery, and over here the superior cerebellar artery. So the oculomotor nerve enters the interpeduncular cistern and runs between the posterior cerebral artery and the superior cerebellar artery. Let's move on to the nucleus of the trochlear nerve, also located in the midbrain, but in the lower midbrain, also located at the back in front of the cerebral aqueduct. So a bit similar like the oculomotor nucleus, only lower in the midbrain. But this nerve does something funny. So the fibers of the trochlear nerve do not exit the midbrain anteriorly. No, it's the only cranial nerve to exit the brainstem posteriorly, and it also decussates. It's the only cranial nerve to do that. So the nucleus, let me think. So the right trochlear nerve, responsible for innervation of the right superior oblique muscle, has its nucleus on the left side of the midbrain. So there's decussation of the fibers, and as said, the only cranial nerve to do that. And finally, we have the abducens nerve located inferiorly in the pons, also at the back in front of the fourth ventricle. And we see these like very small protrusions over here in the fourth ventricle. These are called the facial colliculi, and they are a way to recognize the approximate location of the abducens nucleus on imaging studies. The fibers run through the pons. They do not decussate, and they exit the pons anteriorly. And here at the level of the pontomedullary junction, and here we see the cisternal segments of the abducens nerve. Okay, let's now move on to the cisternal segments. We already touched upon them, but here we have the cisternal segments of the oculomotor nerve and the interpeduncular cistern, and this is a coronal image, and on this coronal image we nicely see the anatomy of the basilar artery, and on top of the basilar artery we see the two posterior cerebral arteries and the two superior cerebellar arteries, and the dot in between is the oculomotor nerve and the interpeduncular cistern. And this anatomy is quite important because it will explain why in some cases the oculomotor nerve can be compressed by certain vascular structures or by aneurysms. Let's move on to the cisternal segment of the trochlear nerve. As said, the trochlear nerve exits the brainstem at the back, typically at the level of the medullary velum, which is a small leaflet covering the upper part of the fourth ventricle. So this is where the cisternal segment exits the brainstem, and as said, it crosses to the other side. So these arrows here indicate the right trochlear nerve, and here shown in orange is the tentorial ridge. So the tentorial or the tentorium rather, and the trochlear nerve exits the brainstem, enters the ambient cistern, and then runs in close proximity to the tentorium. Let's look at this other patient. Because the trochlear nerve is so thin, it is often difficult to visualize. So if you can't really see it on your high-resolution T2-weighted images, don't panic. That can still be normal. It's not always easy to see it. So here is the medullary velum. Here we see the tentorium, and here we see the right trochlear nerve and the right ambient cistern, and here we have the left trochlear nerve. And the nucleus here for the right trochlear nerve is located on the left side of the midbrain, as already said. So some of those things I already told you. So the trochlear nerve is the smallest of all cranial nerves. It has the fewest number of axons, making it sometimes very difficult to visualize. It's the only cranial nerve to decussate and to exit the brainstem dorsally. And it's also the cranial nerve with the longest cisternal segment, so the longest segment running through the basal cisterns. But that will also make this nerve quite susceptible to trauma. It's very thin, it's very long, and it runs very close to the tentorium, which is a very rigid structure. So when it compresses the trochlear nerve, it can damage the trochlear nerve, which can happen in situations associated with increased intracranial pressure or in trauma. Then the cisternal segment of the abducens nerve, as said, the abducens nerve exits the brainstem at the level of the pontomedullary junction, and then it runs superiorly and laterally towards the clivus, as we can see on these consecutive images, which are always, I'm scrolling upwards here. And then we see it entering a small channel located at the back of the clivus, which is called Dorello's canal. More about that in a minute. Let's look at these sagittal images, and then this time I'm scrolling from medial to lateral, or from medially to laterally. So here we see the abducens nerve exiting the brainstem at the level of the pontomedullary junction, and I scroll a bit laterally. Here is the abducens nerve. I still see it over here, and here it's entering a very thin T2 hyperintense channel called Dorello's canal. What is Dorello's canal? Well, let's first still look at this sagittal image or parasagittal reconstruction I made to show you the course of the abducens nerve in one image. So here we see it exiting the pontomedullary junction, and here we see it entering Dorello's canal. Okay, what is Dorello's canal? Dorello's canal constitutes the so-called interdural segment of the abducens nerve. I told you the abducens nerve has an interdural segment. The oculomotor nerve and trochlear nerve don't have that. What is it? It's a very small dural-lined channel located in the venous plexus at the back of the clivus. Let's try to recognize it on images. So over here we have the abducens nerve, and we see a very small protrusion over here filled with cerebrospinal fluid, T2 hyperintense. That is Dorello's canal. If you look at these on these T1 weighted images with gadolinium, so what is Dorello's canal? I already told you it's a small fibrous canal located between two dural layers containing the abducens nerve, and it is located near the petroclival junction. So here we have the clivus, and here we have the petrous apex. So it's located in this junctional area, situated within the venous plexus located at the back of the clivus. And here we see a very small hypointensity in this contrast enhancing venous plexus. This is the abducens nerve in Dorello's canal. Okay, these images might be a bit difficult, especially this one over here. What is this exactly? Well, this is the pons. It's a parasagittal reconstruction I made, so that's why it looks so strange. We're not used to looking at images in this plane, but stay with me. So this is the belly of the pons, easy to recognize, I believe, and this is the cavernous sinus. We see the internal carotid artery over here, the cavernous segment, making its famous two turns, so that's also clear to recognize. Then here we have the bony structures of the petroclival junction, and we see some enhancement at the back. This is the venous plexus. And if we now look at this hypointensity over here, this is Dorello's canal. So this is the presumed course of the abducens nerve. Here it enters the venous plexus in Dorello's canal, and it runs upwards towards the cavernous sinus. And all oculomotor nerves, all extraocular motor nerves rather, eventually enter the cavernous sinus. So Dorello's canal is very important, so we can easily recognize it on contrast-enhanced T1 weighted images. We see these two hypointensities in the venous plexus, that's Dorello's canal. So it's very important because the abducens nerve is very firmly fixed in Dorello's canal, and that will become important in situations like trauma or in situations with an increased intracranial pressure, because the abducens nerve is so fixated or so fixed in the Dorello's canal, it will become very susceptible to stretch injuries, or the cisternal segment will become very susceptible to stretch injuries. Okay, let's now talk about cavernous sinus. So this is the one weighted image with gadolinium, and let's magnify this region a bit. What do we see? This is the pituitary, and next to the pituitary we have two contrast-enhancing structures. What are those? These are dural-lined venous channels located on both sides of the pituitary and the sella turcica. These are the cavernous sinuses, and they contain the internal carotid arteries, the cavernous segment, and several cranial nerves, including the extraocular motor nerves. So, the cavernous sinus can easily be identified on coronal images as well. So here we see the pituitary, and this is the optic chiasm, and then we see these hypointense regions with flow voids. This is the internal carotid artery, and the cavernous sinus is basically the venous structure located along it, and we see it enhancing on these coronal T1 weighted images with gadolinium. So once again, here's the pituitary, this is the pituitary stalk, this is the optic chiasm, here we see the internal carotid artery, and then the enhancing structures or the enhancement along it, next to the pituitary and along the internal carotid artery, those are the cavernous sinuses. Okay, the cavernous sinuses have a quite complicated anatomy, so my apologies. Let's go into a bit more detail. So, as said, what are they? They are dural layered venous channels located on both sides of the sella turcica or the pituitary fossa. And why the name cavernous? Because they are divided into caverns by very small fibrous septa. And they contain several extremely important structures. Like centrally within the cavernous sinus, we find the internal carotid artery, the cavernous segment, but also the abducens nerve. Then in the lateral wall of the cavernous sinus, which is a very quite rigid piece of dura mater, we find the following cranial nerves. We find the oculomotor nerve, the trochlear nerve, and also the ophthalmic branch and the maxillary branch of the trigeminal nerve. Now, because the abducens nerve is the only cranial nerve in the cavernous sinus that is not located in the rigid dural wall, this cranial nerve is most susceptible to becoming damaged when a process involves the cavernous sinus. The other cranial nerves are relatively protected by being located in the lateral wall. That doesn't mean they can't become damaged, but the abducens nerve is generally the first cranial nerve to become symptomatic when a process involves the cavernous sinus. Okay, let's now try to find our various cranial nerves on radiological images. And thanks to my former colleague, Dr. Stefanie van den Bosse, for providing me with this image. It might take some getting used to, but you can actually recognize all cranial nerves on this magnified T1, coronal T1 weighted image with gadolinium centered over the cavernous sinus. So we see the pituitary over here, we see the cavernous segment of the internal carotid artery, and then, okay, there it is, the internal carotid artery, and then on top, in most cases easy to recognize, we find the oculomotor nerve. Then we have the ophthalmic branch of the trigeminal nerve, and here we have the maxillary branch of the trigeminal nerve. The trochlear nerve is very, very small, but can be presumed, because it's located in the cavernous sinus inferiorly of the oculomotor nerve, and then sometimes recognizable, in a lot of cases not recognizable, but here we can see it. We find the abducens nerve located centrally within the cavernous sinus. Now, of all these cranial nerves, the one that is most easy to recognize and most consistently recognizable would be the oculomotor nerve, typically located superiorly and laterally in the cavernous sinus. So, and this I already explained to you, due to its central location, the abducens nerve is the most vulnerable of all cranial nerves in the cavernous sinus. Okay. Now, as said, the oculomotor nerve is most easy and most consistently recognizable, and something that helps is that it's often surrounded by a thin rim of cerebrospinal fluid. That's because the oculomotor nerve is located in a oculomotor cistern, which invaginates the cavernous sinus and generally enters the cavernous sinus over a variable distance. It's a very important landmark, both for the neurosurgeon who has to operate in that region, but also for radiologists, because, and if this is the first time you've heard of the oculomotor cistern, I'd advise you, if you do like coronal T2 weighted images or coronal T1 weighted images with gadolinium, now look at the cavernous sinus and try to recognize the oculomotor nerve. And I bet you, in a lot of cases, you will be able to recognize the oculomotor nerve. So here we have the cavernous sinus, and we see these two dots surrounded by a thin rim of cerebrospinal fluid. Those are the oculomotor nerves located within the oculomotor cistern. And we can also see it here on this extremely magnified high-resolution T2 weighted image. This brings us to the final segment of the extraocular motor nerves, the extracranial segments, which, as said, the extraocular motor nerves enter the orbits through the superior orbital fissure and then run intraorbitally. So this is the final segment. Here we have the superior orbital fissure. This is located laterally of the optic canal, which is located somewhere over here. And here we have the inferior orbital fissure, but that's not interesting to us in this presentation over here. So can we recognize the superior orbital fissure on plain axial CT images? Yes, we can, without much of a problem. The superior orbital fissure is located between the greater and the lesser sphenoid wing. So it's located over here, and it's typically located laterally of the optic canal. So through the optic canal enters the optic nerve and also the ophthalmic artery, and through the superior orbital fissure enters, well, the oculomotor nerve, which has two branches. It has, by the time it enters the superior orbital fissure, divided in a superior branch and an inferior branch. The superior branch is responsible for the innervation of the superior rectus muscle and also the palpebrae superioris, and the inferior branch innervates the remaining extraocular muscles innervated by the oculomotor nerve. And also, as such, so we have the two branches of the oculomotor nerve, the trochlear nerve and the abducens nerve, entering the orbit through the superior orbital fissure, but also several trigeminal ophthalmic branches, sympathetic branches coming from the sympathetic plexus around the internal carotid artery, and the superior ophthalmic vein. Now, for the sake of this presentation, it suffices to know that through the superior orbital fissure, all extraocular motor nerves enter the orbit. The optic nerve enters through the optic canal located medially of the superior orbital fissure, and then we have through the superior orbital fissure the superior branch and the inferior branch of the oculomotor nerve. Here we have the abducens nerve innervating the lateral rectus muscle, and here we have the trochlear nerve innervating the superior oblique. Okay, this brings me to the third part of this presentation, pathology. And I'm going to close this presentation now and probably already upload it, and then I'm going to continue with the second part of this presentation, because otherwise it will become way too lengthy. So see you soon for the second, well actually the third part of this presentation on extraocular motor nerve anatomy and pathology. See you then.